routine practice in many centers. So now we've got the questions here for all the speakers, and already before starting the webinar we had some questions. So I will start a little with the first question that we got before starting the webinar, which is to David, Dr. Fanaoni. So the first question is, what can be the etiology of low cardiac output syndrome in a child with multiple muscular VSTs, with less than 1 hour of cross-clamp time and del nido cardioplegia for myocardial preservation, and who has a normal preoperative myocardial function?
Thanks, Mona. I think it's a very interesting question, because I guess the reason why it's asked is because it's really uncommon to see low cardiac output syndrome in a patient like that. The two things I would say: first of all, those patients are known to usually have low, decreased LV function afterwards. It's been shown many times. They usually recover within 1 to 6 months. We've seen that many times at sick kids as well. But I guess here the question is low cardiac output syndrome, which is unusual because the patient is coming to surgery with a good function. It's a pretty short bypass, short clamp time. And they use del nido cardioplegia. What I would say, usually when I see cases like that, I always blame the surgeon. And I think in one of those cases, we've seen that patients with low cardiac output syndrome that are usually unexpected, and most of the time it's before a poor myocardial protection. We do use del nido as well. And I guess Vivian can comment on that, because she's from Boston with del nido. It sometimes is for the surgeon, for our surgeon, it took them quite a bit of time to get used to it, because it's a long-acting cardioplegia, and so you usually don't have to repeat it as often as you would with a different cardioplegia. And when we switched to del nido, we had a few bad outcome about myocardial protection, and I think it's just because we were not using the cardioplegia as it should be. So that's something that you always have to keep in mind. And there are some very rare and specific cases where sometimes we've had patients with an RV fistula that we didn't see pre-op, and coronary to RV fistula, and then the cardioplegia was not delivered properly. So most of the time, I would say it's related to myocardial protection when you see an unexpected low cardiac output syndrome. So I would say in this case, that's what I would blame. I don't think I have any other reason specific in mind, other than those patients are known to have low LV function sometimes, and sometimes for a while, but not typically low cardiac output syndrome.
Okay, or be there and tell them that the cardioplegia should be done well, and look at what they are doing. Maybe observing the surgeons a little bit more. That would be maybe also a tip for these cases. Thank you. Another question for you is that Pico is an interesting cardiac output monitoring method, even during an open chest surgery, or only for postoperative period. So what do you think? Is it only for intraoperative period, or also for the postoperative period?
Well, I think that's a good question, and I remember using the Pico for a while, and I think I ended up being disappointed. Because I think when you have it in the OR, I mean, if you insert the catheter, you have it in the OR. So I started using it in the OR, but intraoperatively, it's so hard to get an accurate measurement because there are so many things happening at the same time. So I didn't find it very helpful, to be honest with you, in the OR. It's sometimes probably better used in the ICU. Because I think it's more of a steady state. There's less manipulation of the patient and so forth. So in the ICU, it can be used, I think, more accurately. That being said, our intensivists didn't like it, and I think it's just because they have access to echocardiography pretty easily, and so I don't think we kind of stopped using it just because we thought it was not. And sometimes it's the numbers you get are all over the place. So I think it's hard to use intraoperatively, maybe postoperatively, but I think in the post-op period, at least in our intensive care, they didn't really like it.
But even if you want to use it in the postoperative period, you still need to insert the arterial line intraoperatively, or you don't do that?
I would, like I used to, because I think you need the art line for the case anyway. So we would insert it at the beginning of the case, and then we would have it. So we would try to use it. But so I would, unless you have a very specific case where you only wanted to have, you realize that the patient has a low cardiac output syndrome, for example, as question number 1, and then you don't really have another tool to monitor, and then you want to insert it postoperatively. I think but that will be like a very, very rare occasion. Yeah,
thank you. We have some questions for Dr. Schindler. The first question that came before the start of the webinar was, can we use miron and doputamine simultaneously for a synergistic effect?
Yeah, well, it's a little bit difficult question to answer because, it's if you want to combine a inodilator with another inodilator, might not be a very good idea, because it can result in a very tachycardiac situation, because you have a massive vasodilation and beta-adrenergic stimulation. So I think that might not be a very good idea.
Okay. Another very interesting question for you is, could you comment on the role of arginine, vasopressin, and teleporosin in low cardiac output syndrome and pulmonary hypertension?
Yeah, well, as you could see from the slides comparing Denmark to the United States, we are very rarely using vasopressin, and I never ever used teleporsin in my life. So I just can repeat data from the literature from there. But from my point of view, I think if you have a right ventricular failure together with pulmonary hypertension, you first try to open up the pulmonary vascular system to lower the pulmonary vascular resistance, and then vasopressor can be a good idea, as I described, that you can shift the septum back to the right side. So I don't know if noradrenaline or vasopressin or telepressin is better or not. I would suggest to use a vasopressor in those circumstances.
Yeah, we as an adult and pediatric anesthesiologist, sometimes in adult cases we very rarely, of course, we use vasopressin to treat refractory shock, but I have never used it in pediatrics, and I'm always afraid for the effects of vasopressin on the kidney. So I don't know. There is not so much literature over there on the use of vasopressin in pediatric cases. Now, of course, pulmonary hypertension, low cardiac output syndrome is another specific case. So it's always difficult to know what to do. Okay, so this is of course still an open question. We don't have so many data on the use of vasopressin.
And maybe there's a difference if you look at, for example, if you have problems coming off bypass and treatment on intensive care due to refractory septic shock. I think these are two maybe different etiologies.
Mm-hmm. Yeah. Now, another question for you that is actually a little bit contradictory to what we have just said is that the question is, in a failing heart, unlike in sepsis, will it not encounter more afterload, the use of vasopressors, and so don't we get more failing heart in case we use vasopressors as a first line therapy? So there's somebody that doesn't believe in the use of vasopressors because it will increase the afterload in a failing heart, unless it's in sepsis.
Yes, I think that was my example in the diastolic heart failure. So diastolic heart failure means if we have if if diastolic right ventricular failure, if the right ventricle is not working and is shifting the intraventricular septum to the left side, the left ventricle gets smallish, and it's very difficult for the left ventricle to act. So in those cases, it can be a very good idea to increase the peripheral vascular resistance to make it more difficult for the left ventricle to open up. So then the septum can be shifted to the right side, and maybe the overall geometry of the both ventricles can be increased. So that can be an indication for a vasopressor. It depends on the indication. So you have to see what is the reason of the left or right ventricular failure, and then find your decision what to do.
Mm-hmm. Thank you. Now, we always speak about left and right heart. The question is, of course, what about single ventricles? That's, of course, another topic. I think it's we can speak for hours about management of low cardiac output syndrome in single ventricles, because that's still very different. But yes,
in single ventricle, the question is if they are treated, for example, with the Norwood 1 circulation or not. If you have an untreated single ventricle, you want to keep the balance between pulmonary circulation and systemic circulation. So that should be ideal, 1-to-1. So if you have a saturation in those patients of about 85, you can estimate that this is a kind of a balanced circulation. If you have a procedure after Norwood 1, for example, you also try to aim this circulation, and then you, for example, I would measure SVO2, and if we have a very high SVO2, I would suggest to decrease a little bit, to increase the peripheral vascular resistance, for example, with noradrenaline a little bit. And if we have a decreased SVO2, I would say we need an inotropic agent like adrenaline or milrinone combination to make it more easy for the ventricle to inject.
Yeah, thank you. Thank you very much. We have a question for Dr. Bourgeon. The question is, if milrinone for preventing low cardiac output syndrome has small evidence, should we use it in all cases then?
What happens, milrinone works very well in very young children. And the first time it has been shown to work, it has been demonstrated in a population less than 6 years of age. So in this kind of population, there is a pathophysiological basis to it, and the mechanism of action is very clear, and we see it works. The problem with the big data is that, and big meta-analysis, that we pull together very heterogeneous populations. Milrinone doesn't work in adults, or very little effect. In teenagers, again, very little effect. So above the age of, I would say, 2-3 years, there's very little effect we see with milrinone. So putting together 0 to 18 years, of course, we won't find any effect, but doesn't mean that in very young children it doesn't work. So my feeling is we should use it, but in very young children. For instance, in my institution, all children less than 1 year of age would receive a prophylactic, well, it's not milrinone, it's amrinone, but it works the same way. But an older one, 5 or 6 years old, will not receive milrinone, that's for sure. So that's why the meta-analysis is negative, but doesn't mean milrinone doesn't work. It's just a sad story of meta-analysis.
Yes, of course. You need to look at all these meta-analyses very carefully before changing your clinical practice. But now another question is maybe also in the same line for you, is to individualize the recipe. We need a good point of care diagnostic tools, modalities. And what is your best diagnostic tool to detect, for example, low cardiac output syndrome?
Yeah, so there's not one tool. In my experience, of course, echocardiography is a major tool. So in those patients which are unstable, they have several assessments during the day, not just one. So this echography is a major thing. Now, then we need also this other tools which have a very on-off, where we can act on-off. We can see immediately what happens. For instance, lactate is very popular, but lactate will take hours to increase, and then maybe we arrive a bit late to ameliorate the situation. But as Vivian showed it, near-infrared spectroscopy is a very good tool. So the multi-site monitoring of NIRS is a very incredible tool. The problem is it's a bit expensive. But we can also monitor venous saturation, which is almost the same thing as NIRS, and that is immediate, and you can immediately see when the patient is in low cardiac output situation. And then, unfortunately, I think it's also a question of experience, because we all agree that you're a better anesthesiologist when you're 40 than when you're 25 or 30. And in ICU, it's a bit the same thing. So the importance of training in a big center, having seen many patients, having managed many patients, is also something which is important.
Okay, thank you. Thank you very much. We have still room for one last question, and for the other questions that will not be answered this evening, they will show up on the website and will be answered by the speakers. So the last question is for Dr. Nasr. The question is any of the 5 NIRS equipments that you have shown in one of your slides, do they provide deoxyhemoglobin and oxygenated hemoglobin values?
That's an interesting question. I honestly do not know if the technology presents these values. We used Foresight at Boston Children's, and I do not recall that these numbers are presented to us. I don't know if anyone else on the panel.
Not all of them present this. No, unfortunately. Yeah. Okay. That's it's still a thing that we need to have. NIRS, the use of NIRS still a technology that needs improvement, and we all know that there are drawbacks with the use of NIRS in adults, but also in children. Mm-hmm. Now, I would like to thank all the speakers for their excellent presentations. And this brings me to the session of conclusions. And that's that actually, when I listen to all the speakers, we see that the management of children with coming to congenital cardiac surgery is actually very challenging. We don't have so many diagnostic tools. We still use our old-fashioned methods to make the diagnosis of low cardiac output syndrome, and that even if there are studies available, we need more evidence-based to know what is the best drug that we need to use to prevent low cardiac output syndrome, and we have seen many surveys. But of course, we still need well-designed studies on the use of inotropes and vasopressors, but also on the use of other diagnostic tools such as NIRS and so on. And again, thank you very much to the speakers for these presentations. And I will give the talk to Professor Eltahan to conclude this webinar. Thank you very much for being with us this evening. Bye-bye.
Thanks so much, Mona, for this great efforts. And on behalf of the EACTA Board of Directors and the Educational Committee, I am delighted to thank all talented speakers today and the great efforts exerted from them and Mona. You have to know this webinar idea born in July 2018, and we started to work on this on September 2019, so take a lot of time and efforts to conclude it. I would also to thank the organizers from AM, and special thanks to the heroes behind the scene from multi-learning, because it was very challenging today to introduce for you polls and collect votes and trying to present them in light of some technical challenges. And you have to know this webinar is accredited by 2 CMA credit points, and you have to fill the feedback and to receive your certificate according to your attendance. And this webinar is totally supported by EACTA. And at the end, thank you very much for everyone. We appreciate you being here tonight. And I have to remind you to mark your calendar that the next webinar, it will be from the ventricular assisted device EACTA subspecialty committee about ventricular assisted device. It will be on November 9 and 17 to 19 Brussels local time. Thanks again for joining us today, and we'll see you next time. You can follow the unaddressed questions and the results of polls on the website and social media. Thanks so much and have a nice evening.